The following podcast is part of a certified educational activity titled Addressing Unmet Needs in Non-Small Cell Lung Cancer, Elevating MET Targeting Options for Patients with a Poor Prognosis. Access the entire activity and complete the post-test at peerview.com/JZU860. Downloadable slides and practice aids are also available.
Thank you very much for joining us. We're here to speak about addressing unmet needs in non-small cell lung cancer. We're talking about elevating MET targeting options for patients with a poor prognosis. My name is Jonathan Goldman. I work at UCLA, where I focus on clinical trials in thoracic oncology and drug development. I have the pleasure of being joined by two colleagues who I would ask to introduce themselves.
Yeah, thank you. I'm Gregory Fishbein. I'm a pathologist, a thoracic pathologist at UCLA. I work closely with Dr. Goldman. I'm the chief of autopsy pathology and the chief of cardiothoracic pathology.
And I'm Caroline Maxwell. I'm an oncology nurse practitioner. I also work closely with Dr. Goldman at UCLA in Santa Monica, California.
It's great to be here with my two colleagues as we talk about the optimal care for our non-small cell lung cancer patients. A multidisciplinary approach is crucial to providing the best care, and that's why we wanted to speak with you together. Today, we're going to focus on biomarker testing, implementing testing for MET overexpression to identify patients with non-small cell lung cancer who are candidates for MET targeting therapy. We're also going to talk about the latest evidence regarding that MET targeted therapy, and in particular, antibody drug conjugate treatment for patients with high c-MET overexpressing non-small cell lung cancer. And lastly, talk about how to educate and engage patients, how to manage toxicities, and provide the best multidisciplinary care. We have the great fortune of being joined in this project by the MET Crusaders. They're providing very important patient perspective, giving patient resources, and being a crucial voice in this discussion. We'll start by talking about biomarker testing. Really, I think it's a significant truth in modern lung cancer care that it all begins with biomarker testing as we try to best understand each individual patient's tumor and tailor their therapy for the best outcomes. The MET oncogene is something that is perhaps unrivaled in the different ways that it can affect oncogenic potential and activity of tumors. The MET gene is on chromosome 7. It is active in a disulfide-linked alpha-beta heterodimer. There is a SEMA domain, which is the receptor for the ligand hepatocyte growth factor, also called scatter factor, a juxtamembrane domain, and inside the cell, the tyrosine kinase catalytic domain. Just below the cell membrane is the Sybil binding site, CBL, and that is the main negative regulator of MET activity. So one of the ways that MET signaling can become aberrant and lead to cancer is loss of that Sybil binding site. We'll talk about that on the next slide. Exon 14 skipping mutations were described quite recently. We were actually the first group to identify a patient with an excellent response to the MET tyrosine kinase inhibitor crizotinib. It was later elucidated, the pathophysiology here, that mutations can lead to the exon 14 part of the protein not ending up in the final protein. This therefore removes that negative regulator Sybil binding site and causes abnormal MET signaling. Because of the variety of mutations that can lead to this phenotype, we found that different testing techniques have different benefits. DNA testing alone, typically by NGS testing, will catch many, but may miss as much as 50% of these exon 14 skipping mutations. Adding in an RNA NGS panel improves the sensitivity significantly, and that's because you're able to very specifically identify whether exon 14 is in that final protein or not. The patients with MET mutations are somewhat different than some of the other driving mutations, a little bit older than others, equal male-female split. Many, but not all, are non-smokers. There is about 90% are adenocarcinoma, but a significant minority have squamous cell. So one pearl I've always thought of is a squamous cell patient with no smoking history. There's a significant chance that they may have a MET exon 14 skipping mutation. And about 10% of these patients have brain metastases at baseline. Another way that MET can act as a driver is through amplification. Because amplification can be a spectrum from low-level to high-level amplification, and associated with that either a low or strong oncogenic signal, it has been, I would say, more difficult to develop MET amplification as a target for therapy. One of the early studies looked at crizotinib and showed that low and intermediate level amplification had some benefit, but it was really in the high amplified patients that had the most significant benefit. Something similar was seen with capmatinib, but in neither case was the signal strong enough to allow development of those drugs specifically for that indication. We'll now move to MET overexpression, and importantly, this is clearly the largest group of patients. MET exon 14 skipping mutations, certainly under 5% of patients. Amplification also 1 to 2% of patients. Overexpression, a much higher group if you include intermediate and high level overexpression of MET, about 30% of patients. It was found early on to identify patients with a poor prognosis, a higher recurrence risk regardless of stage after surgery. And that's demonstrated in some of these trials going back as much as 30 years. Looking for the prevalence of this oncogene and poor prognostic factor, it's been shown in several studies, including this real-world data analysis from multiple countries and multiple data sets, showing that across many different subtypes of patients, expression rates are similar. Similar rates in men and women, different parts of the world. Smoking certainly, patients that smoked certainly can have MET overexpression, about 36%. In this particular trial, there were only a small number of non-smokers, but we do know from other data sets that non-smokers can also have MET overexpression. And then on the right, there are several other tumor characteristics, including TNM stage, line of therapy, etc. Did not seem to clearly identify one group as being more likely than another to have MET overexpression. So an important point is to think about testing all of your patients. This data set also confirmed that high MET overexpression and intermediate MET overexpression were associated with poorer prognoses. When we think about biomarker testing, we often have to consider how there may be overlap with other biomarkers. So MET overexpression, we know, can be an additional factor in the pathophysiology of tumors that have other oncogenes. So at the top there, you have EGFR mutant and wild type, next KRAS, BRAF, ALK translocation, and ROS translocation. And in most of them, except for BRAF, each of the mutated groups is more likely to have MET overexpression. This is an important area of future research, how MET targeting may be added to a TKI therapy. Several research programs have developed this concept in patients with EGFR mutations and progression, and there's likely lessons that can be transferred to other oncogenic subgroups as well. There is interesting correlation with PD-L1 expression, particularly the high PD-L1 overexpressed groups, meaning over 50%, also seem to have a high MET overexpression, and more about how that may affect treatment options and best outcomes may come from ongoing studies that are looking at MET-targeted therapies in combination with immunotherapy. Lastly, just to focus on the MET group, patients with the MET exon 14 skipping mutation, we know that there is significant overlap, but not exact equality. Those groups are meaning that there are patients with MET mutation that may not have MET overexpression, and certainly there are patients with MET overexpression that don't have MET mutation. So when we're looking at these biomarkers, we need to think specifically about what we're interested in. For the TKI therapies, at right now, exon 14 skipping mutations are the treatment deciding factors. When we're looking at MET antibody drug conjugates, we're going to focus on immunohistochemistry.
Right. As you said, MET overexpression is determined by immunohistochemistry that's interpreted by surgical pathologists. There's always a concern about interrelated reliability between a pathologist, and one thing we learned from this real-world study where the immunohistochemical stains were interpreted by both the local and the central laboratory was that there's fairly good agreement between the local pathologist and the central pathologist in deciding both intermediate grade c-MET overexpression and high c-MET overexpression, defined as greater than or equal to 50% of cells with high intensity staining. When a biopsy is received by a surgical pathologist, our first task is to establish the histologic subtype, that is adenocarcinoma, or I should say non-squamous versus squamous cell carcinoma. The biomarker testing is quite complicated, and this has largely fallen into the realm of the pathology workup. So once we determine the histologic subtype, at our institution, it's the pathologist who initiates the biomarker testing. There are numbers of ways to do this. So we often have meetings quarterly to determine how we're going to use this precious tissue and divide it up to accomplish all of the testing. At our institution, the pathology lab cuts all the material for these tests up front so that once we make a diagnosis, we can rapidly send the material to the appropriate laboratories, whether it's for immunohistochemistry staining or for DNA or RNA sequencing. As you can see on the right, there's a number of biomarkers that need to be evaluated, and the red box is demonstrating that immunohistochemistry plays a role here in evaluating HER2 and c-MET expression. The interpretation of the immunohistochemistry for c-MET is similar and different to HER2 and for PD-L1. We start by estimating the number of tumor cells that express the marker, and we proceed to evaluate the strength of expression. This is semi-quantitative. 1+ would be weak, 2+ would be moderate, 3+ would be strong. We're interested in specific compartments. So for PD-L1 and HER2, we're actually only interested in membranous staining, and that can be partial or that can be circumferential or complete. For c-MET, we're interested in both membranous and cytoplasmic staining. And the reporting of the staining is done a little bit different for each biomarker. The interesting thing about c-MET is that we care about both the number of tumor cells that are expressing the marker as well as the degree of expression. So a percentage of tumor cells at 3+ staining would be high 50% or more would be high expression. And then you can see that there's 1+ staining would be low expression and 2+ intermediate expression.
Thanks very much, Greg. I think that was an excellent review of a very complicated and dynamic area. I'm interested in your experience of this change. We, not that long ago, had a system where the patient would get a biopsy. It might be read as adenocarcinoma of the lung, and no further testing would be done until the patient was seen in oncology and additional tests were ordered. That was leading to really significant delays. You might meet a patient and not have all the information you needed until maybe 3 or 4 weeks later. How has this multidisciplinary collaborative approach impacted your experience taking care of or being part of these patients' care?
Yeah, that workflow you described where the biomarker testing is initiated by the oncologist is still largely how this is practiced. Um, but there has been a shift, is particularly with non-small cell, and it's made things very complicated for the pathologist because we often receive very small amounts of tissue. So we need to have a plan. You need to have a protocol. If I were to wait for you to tell me all the different stains you want, I would have to recut into the tissue blocks, and frequently run out of tissue. So that's why we work so closely together. We come up with a plan. We know exactly how many immunohistochemical stains we're going to need for diagnosis, for biomarkers. We know how many slides cut at a certain thickness we're going to need for panel testing and for DNA sequencing and for RNA sequencing. The other advantage to having that plan is that we are rapidly able to get this material to laboratories. I think when we initially had turnaround time discussions, we would be very compartmentalized and say, well, it takes me this amount of time to turn this around, but not really accounting for the amount of time it takes to get the slide to the laboratory, for the laboratory to initiate things, because all of these will basically just drag on that turnaround time and make it larger. So I think we've largely been able to rapidly turn these tests around. And I'd like to know if you agree that this has been a major improvement.
Yes, absolutely. I think it means that quite frequently when I'm meeting the patient for the first time, we have all or nearly all of the information we need, able to focus on the type of therapy, be it chemotherapy, immune therapy, or targeted therapy, and get onto talking about the specific therapy for that specific patient. It does all of this discussion does take a lot of time and attention. Carolyn, what would you say? How do you talk to patients about their biomarker testing and how that's going to affect their treatment?
Yeah, thank you. So as we know, this information can be very complicated. And especially for, a patient who has newly diagnosed lung cancer, they're getting a lot of information. So it's important to make it easy for them to understand. And so the way I would explain it is, let them know one of the first things we do when we diagnose lung cancer is run some specific genetic tests that help us understand better what's driving the cancer and also how best to treat it. So your results show something called MET overexpression. The MET gene normally helps healthy cells to grow and repair damage. But in some cancers, this gene becomes overactive and the cells make too much of the MET protein. This overactivity acts like a stuck gas pedal, sending signals that tell the cells to grow and divide. Knowing this helps us personalize your treatment because there are specific targeted therapies to block MET and slow the tumor's growth.
Great. I think that you're absolutely right that patients often find this experience overwhelming in the midst of a difficult diagnosis. But I think that described it very clearly. Thank you very much. I think we're ready to move on to our next section about how we implement these biomarker tests in our treatment decisions. So now we'll talk about how we use biomarker testing for clinical treatment decisions. Maintaining the title puns, we're going to be talking about parameter change and emerging evidence for novel targeted therapies. We mentioned previously that MET exon 14 skipping mutations have been identified and that therapy with oral TKIs, capmatinib and tepotinib, has transformed care for these patients. Response rates are good in the mid 40%, but perhaps even better in the patients without prior therapy. the progression-free survival can be perhaps less than some of our other patients with oncogenic mutations that we can target. But at the same time, there are some patients with quite significant prolonged responses that can go out years. However, we know that this is only targeting a small subset of MET oncogenic potential. We wanted to talk to you about a novel approach to treating MET oncogene, in this case, MET as overexpression, by using antibody-drug conjugates. Antibody-drug conjugates are rapidly changing care throughout oncology, with approvals in other tumor types as well, including breast cancer. Many of these drugs are often less toxic than chemotherapy and possibly more effective as well. Each of them, though, does have their own array of toxicities that require careful attention and management. Teliso-V vedotin is an antibody targeting MET. It carries with it MMAE, the microtubule inhibitor. It is connected via a cleavable linker. The drug to antibody ratio is about 3, and these have been optimized for maximum benefit and reduced toxicity. The phase 1 trial identified the recommended phase 2 dose of 1.9 mg per kg every 2 weeks, leading to the phase 2 luminosity trial. This was evaluating the drug in a few different subsets of patients and selecting the subset ideal for further study. What was found is the non-squamous, not EGFR mutated, so non-squamous EGFR wild type patients studied both for a CMET high overexpression and intermediate overexpression. And to remind you, high is 3+ staining in 50% or greater cells, and intermediate is 25 or greater up to 50% of cells that are expressing at 3+ MET overexpression. So both of those groups were identified and studied further, meeting the criteria for further evaluation. And these are those results. Overall, in this MET overexpressing group, 28.6% response rate with a almost 35% response rate in the CMET high and 23% response rate in the CMET intermediate. We can get a little bit more granular detail from the waterfall plot on the right, where we see that there is a greater propensity for a good response among the CMET high overexpressors. Most of the patients, significant majority, are getting some tumor shrinkage. Disease control rate at 60%. So all comparing favorably to the previous standard of care options. Prior to approval of Teliso-V vedotin, the usual treatment option was docetaxel with or without ramucirumab, with a response rate in different studies ranging from 15 to 25%. So these results from the luminosity trial suggested a meaningful benefit here, particularly in that CMET high overexpressing group. Part of the appeal of this approach is the tolerability. We'll talk about some of the specific toxicities. The one that requires, I think, particular attention is peripheral sensory neuropathy, seen overall in about 30% of patients, and 7% had grade 3 or higher. That is primarily due to the payload MMAE. We also have some MET-specific toxicities, peripheral edema and hypoalbuminemia, most notably. But I would say for practitioners that have experience with the tyrosine kinase inhibitors, the peripheral edema tends to be certainly less marked with this antibody drug conjugate than it can be with the TKIs. We also have some of the other toxicities that can be seen with MMAE payloads, such as cytopenias, anemia, in particular, but also some thrombocytopenia, some fatigue, and some LFT elevations. We'll also talk further about the ocular toxicities in pneumonitis. When we look at the adverse events overall, we see that peripheral neuropathy was the most common adverse event leading to dose reduction. We'll go into more detail in a later slide. Utilizing dose adjustment and dose holds is often a very successful approach to managing this toxicity. So therefore, we wanted to see, does dose reduction or dose interruption adversely affect outcomes? And this data suggests no. This data suggests that one or multiple dose reductions is not associated with a lower benefit rate. Similarly, dose interruptions for the most part have no suggestion of being negative impacts on benefit. This was seen when you looked at the MET high, the MET intermediate, or the overall MET overexpressing subgroups. The peripheral neuropathy is primarily a peripheral sensory neuropathy. This was measured both as treatment emergent adverse event and treatment related adverse event. This overall was in the low 40% of patients, and grade 2 or greater in 30% or more. The median time to onset is at about a little over 3 months. This was, as I said, a cause of treatment discontinuation, but often quite a number of months into therapy at about 8 months. This does lead to the conclusion that, yes, there was some peripheral neuropathy, but this was primarily in the patients with significant benefit to therapy that were getting treatment response or treatment control leading to treatment for many months. And lastly, talking about was the development of peripheral neuropathy in any way linked to poor cancer control, we found that no, that the patients who developed peripheral neuropathy were in the group of patients that were doing particularly well with response rates of approximately 50% or greater. So now we'll move to talk about some of the management, and I wanted to bring in Caroline here, asking how do you prepare patients for this and how do you follow them while they're on treatment?
Yeah, so as Dr. Goldman said, peripheral neuropathy is one of the more common side effects that we see with Teliso-V. So it's important to educate the patient so that they report, the symptoms, and so that treatment adjustment can be made before the neuropathy could become permanent. So some of the things that I would instruct the patient to watch for: tingling, numbness in their fingers and toes, burning or shooting pains in hands and feet, trouble buttoning clothes, difficulty, picking up small objects, or walking. Also weakness in the hands and legs, and also cold sensitivity. Sensitivity to heat or cold. And then as the healthcare team, the way that we would manage this, we would ask the patient about their symptoms at every visit. Also rule out other causes of neuropathy by checking things such as B12 levels. If the patient is a diabetic, making sure that their blood glucose is under good control. Also, some ways that, we could try to manage the neuropathy is by prescribing medication such as gabapentin. And then if, those modalities fail, we would consider referring the patient to a neurologist at that point for additional support. Some things that the patients can be doing at home: they can protect their hands and feet, wear shoes to avoid injury, avoid very hot or cold temperatures, inspect their skin daily for cuts and burns, stay active with gentle stretching, walking outside, maintaining good nutrition, and telling the team right away if the symptoms start or worsen. So for patients who do develop peripheral neuropathy, there may need to be some dose adjustments made. So for a grade 2 or 3 peripheral neuropathy, the Teliso-V should be held until recovery to grade 1 or less. And the medication can be resumed at the next lower dose level. And then if the patient develops a grade 4 peripheral neuropathy, then the Teliso-V would need to be permanently discontinued at that point.
I do think this really highlights everything that you're saying, that unlike some other peripheral neuropathy, this does seem to be reversible. Most of our patients with a dose hold have significant recovery so that 2 or 4 weeks later, they're able to restart treatment. Now moving to another type of toxicity, ocular surface disorders. This is seen in a lot of antibody drug conjugate therapies, with Teliso-V generally lower grade. About almost 25% of patients did have some toxicity, but almost entirely grade 1 and 2. This would be either dry eye or foreign body sensation. This is often very important to involve ophthalmologists as needed and to encourage patients to use eye drops. The specific terms that were used included blurry vision, keratitis, dry eye, I think being also common, eye irritation, photophobia, and some of the ophthalmologic findings include a punctate keratitis, sometimes called vortex keratopathy, or a limbal cell deficiency is another term that's sometimes used. So, Caroline, how do you discuss this management with our patients?
Thank you for going over some of the ocular toxicities. Um, we may even recommend sometimes that the patient see an ophthalmologist prior to starting treatment, so that they can get a baseline vision test. Using artificial tears to keep the eyes moist multiple times a day is important. If the patient does have some toxicities, at that point, we may prescribe a steroid eye drop. And then, of course, if they do have the ocular toxicity, we would also refer to an ophthalmologist promptly. They should protect their eyes from the wind and sun by wearing sunglasses outdoors, avoid rubbing their eyes, and staying hydrated. And then dose modifications for ocular toxicities. For grade 2, you'll want to withhold the Teliso-V and refer the patient to an ophthalmologist. So it's really important to let the patient know that they should be using the eye drops even while they're waiting for the ophthalmology consult. This can really make a difference in the improvement of their symptoms, so they can start taking the medication again more quickly. So the dose modifications for the ocular toxicity, for grade 2, you'll want to stop the medication and then refer them to ophthalmology. And then once the ocular toxicity resolves, they can restart the Teliso-V at the same dose. Then for grade 3 or 4, at that point, they would need to permanently discontinue the Teliso-V. But many patients, these ocular toxicities are very manageable with, artificial tears or steroid eye drops. And many times, we are able to successfully restart treatment pretty quickly.
I totally agree with all that. And then lastly, we've covered 2 somewhat more common but manageable toxicities. And lastly, discussing a rare but potentially serious toxicity of interstitial lung disease seen with a lot of our novel therapies, including immune therapy, tyrosine kinase inhibitors, and antibody drug conjugates. So what symptoms are you on the lookout for, Caroline?
Yeah. The symptoms that you would instruct the patient to report as signs of pneumonitis, and you want to make sure they know that these symptoms would be different than, as if they got a cold or their lung cancer symptoms. So, for example, like cough, they may already have a cough, but you want to instruct them um, to let you know if the cough changes or worsens, since this can be a sign of pneumonitis. Other things would be shortness of breath, fever. So you want to make sure that they report those right away so that prompt treatment can be started. Otherwise, the pneumonitis can become very serious very quickly. Um, if pneumonitis is suspected, treatment should be stopped. Corticosteroids, such as a prednisone taper, should be started quickly, and patients should be referred to for a pulmonology consult at that point. You may also decide to order some imaging, like CT chest at that point, and then some dose modifications for pneumonitis. For grade 1, you withhold the Teliso-V and start the corticosteroids as soon as the pneumonitis is suspected. And then once there's radiographic resolution, the Teliso-V can be restarted. So for uh, grade 1 pneumonitis, you would want to withhold the Teliso-V and then start steroids as soon as possible. And then as soon as there is radiographic resolution of the pneumonitis, treatment can be resumed. But for grades 2 and above, the Teliso-V would need to be discontinued permanently.
Thank you very much. We do find that different agents have studied how to manage the ILD differently. The Teliso-V pathway was very proactive, and that helped prevent serious outcomes.
Let's now hear from the patient perspective. Please meet Maggie, a patient with stage 4 lung cancer who will share her experiences and thoughts on testing, side effects, joining patient advocacy groups, and the importance of clinician-patient partnership.
Hi, I'm Maggie. I was diagnosed with stage 4 lung cancer in 2021. Prior to my diagnosis, the only symptoms that I had were vision problems, balance problems, and a partial DVT in my leg. I didn't have any sort of lung symptoms at all. When I got diagnosed with a CT scan, the CT scan found that I had stage 4 lung cancer. I knew about cancer. I heard stage 4. I thought that I would go on chemotherapy. I thought I would lose my hair, and I thought it would be gone by the end of the year. But I had my oncologist did a blood biopsy. And with the blood biopsy, I found that I had a targetable mutation, which was the EGFR mutation. I went on a targeted therapy pill, and I was still around by the end of the year, doing well. In the spring of 2023, I had progression, and this time another blood biopsy showed that in addition to the EGFR mutation, I had a MET amplification. This was new to me, and it was explained that the MET amplification was preventing the EGFR TKI from doing its job. It was kind of circumventing the pathway and allowing the cancer cells to multiply. Fortuitously, there was a clinical trial that was starting at my cancer center for people like me that had progressed on an EGFR TKI due to a MET amplification. So I was able to get drugs for both the EGFR and the MET amplification, addressing those. In the spring of this year, 2025, I'd had progression again, this time a tissue biopsy. I had next generation sequencing testing on it, FISH testing, confirmed that the MET amplification was still there. So I went on targeted therapy, again, that addressed both the EGFR and the MET amplification. All of these decisions were made in conjunction with my oncologist. And most recently, with some progression again, I learned about IHC testing, and I learned about antibody drug conjugates. And I also learned that in addition to the MET amplification, I also had MET overexpression, which then opened up a whole new class of drugs for me. Like I said, the ADCs. the one point I really want to convey to physicians and to patients is the importance of biomarker testing and testing like IHC testing or FISH testing, testing for the RNA, the DNA. The only way that we can truly treat cancer patients, lung cancer patients, is through targeted therapy if you have mutations, to specifically address those. It's personalized medicine, and that is what is so important. I have really learned a lot about cancer during my 4 years. I have gotten involved in a lot of advocacy. I naturally want to help people. So I've done peer mentoring. I've led workshops. I'm involved with many different lung cancer organizations. And I am grateful for the drugs that are out there. I am grateful for the testing. And I am very happy to be alive today. I really only recently learned about the CMET testing and IHC testing when I had a PET scan in October. I had a little bit of progression, not enough to do any sort of a tissue biopsy, but I still had tissue sample from a biopsy that was been done in January. So my oncologist suggested that we do IHC testing. And I was the first that I had actually heard of it. And now I really understand the importance of it. He was testing for MET overexpression to see if I had that in addition to the MET amplification. And it was good news when he told me that I did have it, because it opened up the drugs, the ADCs, Teliso-V, a drug that was recently approved, is now a drug that I may go on in the future. With all of the cancer drugs, there is, the way that I look at them is they're killing cancer. So of course, they are going to have some kind of side effects. And it is important from a patient point of view to be able to balance the drug and what the drug is doing to help stop the cancer, but then also to look at the side effects and the quality of life. The MET drugs tend to give edema as a side effect, just the regular MET drugs. And that for me, the edema actually became a problem. And so I had pleural effusion in both lungs that was caused by the edema, not by the cancer. With the ADCs and with Teliso-V, I hear that the side effects, one of the main ones is peripheral neuropathy. There could be some nausea, loss of appetite, possibly some edema as well with the drug. So it's, for me, it's kind of balancing the quality of life. Right now, I'm taking a break from a MET drug, but I may go back on it as soon as the edema really gets under control. And, but it's important when you're talking with your patients as physicians to help them understand what the side effects are, how the side effects can be mitigated. Are there, other drugs that can be given that will reduce side effects? Are there actions that the patient can take that will help reduce side effects? And then also, too, are these side effects permanent? Or will they go away after the drug is stopped? Early on, when I was first diagnosed with the EGFR mutation, one of the oncologists that I spoke with suggested that I join a group online called EGFR Resistors. And so when I developed the MET amplification a couple years later, it was just natural for me to join MET Crusaders. And MET Crusaders are it's like being with your own family or your own clan or something. It's people that understand your mutation, understand maybe side effects. It's really helpful for discussing side effects and how to manage things. I learned about compression stockings. I learned about elevating my legs for the edema side effects. I learned about, what to do about skin rashes. And what were the best moisturizers to use. So I encourage, just like I was suggested to join by an oncologist, join a group, I would recommend that you as oncologists to let your patients know about some of the different online groups, because sometimes you can feel really alone with a lung cancer diagnosis. I appreciate that my oncologist treats me as a person and understands me as a person, understands what my goals in life are, what I like to do, what's important to me. So I'm not just a cancer patient, but I'm a person as well. And so I think that's really important. It's kind of like the bedside manner, and that is really important to patients. My oncologist makes sure that I understand what he's recommending, or what he's talking about. He asks if I have questions. I am so grateful for that. And as physicians, your words matter. You are the expert in the room, and so it's important to think about what you're saying to your patients. I've never had an oncologist tell me that I have an expiration date, and I appreciate that. I mean, I can look at the statistics on my own. I know what they are, but I appreciate that there's always hope in the conversations. There's always like the next step, what the next plan is. And so that is important. Making sure your patients understand, making sure that you understand your patients, and choosing your words carefully to continue to give hope when there is hope.
So we're going to begin with the patient case. And Caroline, would you describe the patient for us?
Absolutely. So in this scenario, we have a 68-year-old man, a former smoker with a 30-pack year history, who presents with a cough and unintentional weight loss. Imaging studies reveal a right lower lobe lung mass with mediastinal lymph node involvement and the presence of bony metastases. A biopsy confirms adenocarcinoma. Broad panel molecular testing shows no actionable genetic mutations. PD-L1 expression is 20%. Patient is initially treated with a platinum-based chemotherapy regimen plus PD-L1 inhibitor and shows signs of progression 9 months after starting treatment.
Well, unfortunately, this is a very common patient presentation where we see a patient who has some markers of potential immunotherapy benefit, but at some point develops resistant disease. And managing this is really central to lung cancer care. There are a few types of presentation of resistance, of treatment resistance, that we might manage differently. For example, a single site of progression in the brain or bone or elsewhere might be treated with focused radiation, and the underlying treatment could continue. But unfortunately, we often see a more widespread progression, and perhaps associated with a clinical decline that tells us that we need to look to our other treatment options. So we talked about this patient's biomarkers, and other than the PD-L1 expression, there were no positive biomarkers that were identified. And we might go back to our pathologist and ask about what other testing could be available, and even if there's enough tissue for further testing. So Greg, walk us through that discussion. How do you, when you get the call that there's some additional testing asked for? How do you approach that?
Yeah, we start by going and looking at what's already been done and how it's been done, because if these tests are done at a different institution, we may have less information than if we were to initiate the workup ourselves, because our initial workup is quite robust. We will look to see what tissue we have that's most recent and what available tissue there is in terms of unstained slides. We wanted to try to avoid cutting into the paraffin block as much as we can, because we lose tissue every time we do that. Once we have a plan, say we need to perform additional immunohistochemistry for CMET and HER2, we would want to make sure that we approach that all in one step, because if we were to do this stepwise, we would lose tissue. So we would go back then and try to cut extra slides so that we have a buffer if anything's needed in the future, and then try to cut the material all at once, as I said. And so then this would probably go to our immunohistochemistry lab, and if any amplification is needed, we would send to our FISH lab. Any more molecular testing needed, we would send to our molecular lab.
And how often do you find that you've run out of tissue?
Unfortunately, we do run out of tissue. So that is something that really does happen frequently. So that might prompt a rebiopsy, but we try to be very cognizant of prioritizing the tests that we think will have the highest yield in cases where we suspect that tissue loss is an issue.
One of the most frequent questions I get is, do you test for MET on the initial specimen or wait till progression? And if you're talking about testing the initial specimen, do you test it at the initial diagnosis, or do you wait till a time like this where the patient's progressed and you're trying to figure out your second treatment option? My overall impression is there's probably not a one-size-fits-all answer to those questions. I think, as you so well reviewed at the beginning, a reflex testing strategy has been very useful in general, and there is some advantage to testing up front and being able to lay out for the patient ahead of time that we have a MET targeted therapy in our back pocket if we need it. On the other hand, you may not get to that point that you need to make those decisions, and so some practitioners do wait until the time that you need to make the decision. At least the immunohistochemistry is usually a rapid turnaround test, so not a long wait there. There is also some interesting findings that there is some increase in MET overexpression as tumors become resistant to therapy. So, for example, you might increase your finding of high expression by up to about 10% by testing a later specimen. I myself have not found that a strong enough difference to always require that I test a new specimen. But if you do have an older specimen and a more recent specimen, I think this is a strong reason to test the more recent specimen. So if we've come to this point and we do have high MET overexpression, particularly in this high group, meaning 50% or greater of cells have 3+ expression, we then present to the patient that we have some treatment options, with the newer agent being Teliso-V vedotin compared to an older agent still in use of docetaxel with or without ramucirumab. We can compare the response rates favoring Teliso-V. There is also, I think, an improvement in general quality of life and tolerability, although really the official testing of that comparison is underway in ongoing trials. But both drugs are associated with peripheral neuropathy, but I would say that Teliso-V peripheral neuropathy does seem to be more reversible than docetaxel peripheral neuropathy, also in general docetaxel has more of the other side effects like asthenia, fatigue, low appetite, and in general decreased functional status. Once we've decided on a therapy of Teliso-V, Caroline, walk us through that process of starting treatment, how you describe the schedule, and discussions with the nurse, for example, for the infusion, and follow-up to review symptoms.
So when a patient first starts treatment with Teliso-V, I explain to them that they'll be receiving an IV infusion every couple of weeks, and that it's really important during that infusion to let the nurse know if they experience what we call infusion related reactions. And so, most of the time, these can be pretty mild. So, really important to stress that to the patient so that they, aren't overly anxious about one of these infusion reactions occurring. And then also, really important to let the patient know that if there were to be an infusion related reaction, we, have ways that we can treat it and stop it. And so, some things that they can, that they'll want to let the nurse know immediately, if they have any flushing, any dyspnea, any fever, um, chills, nausea, chest discomfort, things like that. Um, and then, usually at that point, the nurse would pause the infusion. And some of the time, these side effects will resolve without, any intervention. And then other times, it may be appropriate to um, give the patient additional supportive medications. Also important is if the patient has had a reaction, you'll want to add pre-medication for the next infusion, so that hopefully another reaction would be prevented in the future. But again, really important to let the patient know that we're most infusion reactions are mild and very manageable, and the nurses are used to dealing with these, and so hopefully that helps to make them feel a little bit more comfortable.
Thank you. That's really helpful. And just to again briefly review how you prepare the patient for the possibility of the neuropathy, ocular toxicity, or interstitial lung toxicity.
Yeah. So again, just making sure the patient is educated on, these possible side effects, what the signs and symptoms would be, and making sure they know how to get a hold of you promptly. So, like, if they have any issues after hours, they know, how to call the office and have someone paged, or they know when to even proceed to the emergency room, for example, if they were having some serious shortness of breath. But just making sure that they know what to do and they have a plan in place if needed.
Thank you. I think that really ties together the multiple steps that are required to take care of these patients with appropriate attention and improving their chances for an excellent outcome. We have had some patients on Teliso-V for months and years, and particularly as you get out beyond a year, we sometimes have to hold an infusion for neuropathy, but often by the next visit, they're able to restart as the neuropathy has reduced. The ocular toxicities and pulmonary toxicities are, I would say, significantly more rare and less likely to need attention, but important to have on your radar screen. As we finish up, any other concluding thoughts that you have about where we are or where you think we'll be in the future? Dr. Fishbein.
Well, I think we're in a very good place with regard to biomarker testing, because as we're planning for this testing up front, meeting with you regularly to determine what needs to change, we're prepared to evolve. We have a workflow in place that involves multiple laboratories. We collaborate with the clinicians obtaining the tissue samples to inform them what we need. You inform us what you need. And I think it's very dynamic. So we'll be able to implement changes very quickly.
Thank you. I couldn't agree more. And Caroline, how has your overall experience been treating patients with Teliso-V?
Yeah, I think patients are really happy to hear that there's an alternative to like traditional chemotherapy. And because we can target the specific gene, we're able to deliver the chemotherapy more specifically to where it needs to go while reducing the effects on the healthy cells. So I think it's really nice for patients to have that additional option.
Thank you. That's great. I think we'll leave it there. It's been a great pleasure for me to have this conversation. Thank you, Caroline. Thank you, Greg. And we hope that it was useful.
Thank you very much.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, MET Crusaders. This activity is supported by an independent educational grant from AbbVie.